The theme for this session is health of aging migrants and culturally and linguistically diverse communities. And we have 4 very distinguished speakers today who will be presenting their insights on the topic. I request you all to save your questions for the end of the session, where we'll have a joint discussion. But I'm honored to present the first speaker, Professor Reema Harrison, who will be presenting on healthcare engagement among culturally and linguistically diverse communities. Reema Harrison is a professor at the Australian Institute of Health Innovation, Centre for Health Systems and Safety Research, Macquarie University. She is a mixed methods researcher with a strong track record of translational health systems and services research. Professor Harrison leads a program of research investigating how increasing stakeholder engagement can contribute to improved healthcare quality, experiences, and outcomes. Her work has sought to generate, investigate, and evaluate methods of care through a lens of diversity, specifically in relation to cultural and linguistic diversity, and people with intellectual disabilities. Please join me in welcoming Professor Harrison.
All right, thanks so much for the opportunity to come and speak today. It was a really great first session to provide kind of a backdrop on migration and where things are heading in terms of the Australian population. This session's a little bit of a step change in the sense that I'm really interested in health systems and services provision and what happens to culturally diverse communities when they move through the Australian health system and healthcare services. Briefly, just kind of as a backdrop to this, we know that people from culturally diverse backgrounds often have a very different experience of accessing healthcare services and navigating the healthcare system, and a whole range of different healthcare quality, particularly, and outcomes are associated with that. And Fiona's going to give a lot more kind of detail around that in her presentation, so I'm not going to go into that to a great extent, but I'm really going to focus on healthcare quality. Firstly, I'm going to start off by just defining what I'm talking about in relation to healthcare quality, because I know there's a varied audience here today. So healthcare quality for us is really about the provision of healthcare through the systems and services of care, and whether that is safe, whether people actually have unnecessary harm as a result of the healthcare that they receive, whether it's equitable, whether people are receiving current evidence-based care in a timely way, whether it's effective, and whether it's also person-centric. So we're really interested in looking at that within our team, and we have a particular focus on what's happening for culturally diverse communities in that regard. Several years ago now, I think maybe published in 2020, we did a systematic review looking at what's happening in terms of kind of healthcare safety, so unsafe care in relation to any aspect of health service provision for culturally diverse communities internationally. And we identified through looking at 45 studies in that review that regardless of how you define the CAL community and regardless of which healthcare setting you look at, which country you look at, people from culturally diverse backgrounds generally have a greater exposure to instances of unsafe care, so they'll maybe enter the healthcare system and be more exposed to problems arising in their care that could be prevented. And that has led to a series of work, particularly over the last 4 or 5 years, where we've investigated that in an Australian healthcare context. So this is one of a number of studies over that period where we looked at what was happening for people in CAL communities accessing cancer services in New South Wales and Victoria. Now, in comparison to some of the large data sets that I know that you all work with, this feels very small, but I promise you it took a huge amount of time just going through the medical records of patients in cancer services across those 4 states, and during COVID was no easy task. And so we looked at the records of people. There were 628 records we ultimately looked at. Firstly, we had to identify the CAL community from their patient records, and we used a number of different indicators to try to identify those communities. Incredibly difficult to identify the CAL population in the first place, which is a challenge. And once we did identify those communities, we identified that there were 410 safety events out of 212 records. So that was about 1 in 3 patients having a safety event. And when you compare that to generally what you'd expect in the wider population, it's about 1 in 10 patients. So it's substantially higher than what we expected in terms of identifying safety events within their records. And there were particularly high numbers of safety events in those records where people spoke a language other than English. So the most common kinds of safety events were in relation to kind of medication management. So people either receiving the wrong medication, receiving medication through kind of the wrong routes, wrong doses, that kind of stuff was happening frequently. And clinical processes not running in the way that they were supposed to happen. And there was a whole range of different ways that could work, but that was also common. A lot of it was often put down when we looked at the notes down to things like patient behaviour, and when you looked at the notes it was often apparent that there was a lack of shared understanding between patients and families and health professionals as to what was supposed to happen in care. And so although that was attributed to the patient, often, from our lens, it was a real gap in terms of the way that services were being provided. One of the other things that was interesting really was that many of the records that had safety events in had interpreter not required as listed, but also included somebody that spoke a language other than English. And, we had wonders as to whether there were instances where an interpreter may have been helpful in those encounters. When we looked at the literature review and a whole kind of series of qualitative studies and other pieces of research that we've been involved with over the past few years, there are a number of factors that consistently are identified as impacting on healthcare quality among our communities. Not like this indicates in a linear way at all, but in a really complex and difficult to delineate kind of relationship between systems of care, structures of care, the different kinds of features of CAL communities, and also their different individual and intra-group experiences, whether people are socially isolated, whether people have had past experiences that have led them to distrust healthcare services and systems, and then also the way that our systems are designed. And in the mass of all of the different factors that are impacting on people's experiences of healthcare quality, we've really have to take into account the kind of changing nature of the CAL community in Australia, and that's been really nicely exemplified, I think, in the previous studies. No longer are we just talking about these things that we've always talked about. This is how many people were born outside of Australia, and this is how many people speak another language. Actually, what is it about those particular individuals and their experience that has led them to a path through the healthcare system where they're not experiencing equitable processes and outcomes from their care? And so with that in mind, we've had a heavy focus on healthcare engagement, which is a really broad term, and I've only got probably another 10 minutes or so left, so I'm going to talk a bit about healthcare engagement in relation to CAL communities. When I do work about healthcare engagement, it can be from engagement in an immediate consultation with your GP all the way through to how our system is designed and whether communities have been engaged in the design of a particular model of care or a system of delivering care. And there's lots of different models of healthcare engagement that describe different ways that people can be involved and contribute. This is a really simplified kind of way of describing that, saying, we can have people involved from the point of receiving information about what their medication was supposed to do, for example, all the way through to kind of partnership around how a healthcare policy is going to be enacted for a particular community or what that policy should look like. We've done quite a lot of work looking at healthcare engagement among CAL communities at those various different levels, and there are some consistent barriers and difficulties for CAL communities to engage with healthcare systems, and a lot of those are driven by the systems and the services and the way that we structure those. So they might be realised in the healthcare encounter or in the way that somebody can or cannot engage in a consumer group, but ultimately it's the way that we've designed our systems and services do not necessarily meet the needs of the communities that we're trying to serve. So when we've looked at some of those challenges, I'm going to focus in on a couple of specific kinds of projects. We've looked at what happens for cow consumers and for clinicians and for other staff within cancer services when they're trying to engage together in the provision of cancer care. And we've used a health systems model called the System Engineering for Patient Safety model to look at this. And this just gives us a way of thinking about the healthcare system in terms of various different facets and what happens in each of those different areas. So in one of our studies, we did interviews with about 70 different consumers and staff across services in Victoria and New South Wales. And even if I just focus on kind of one aspect of this, so that the task of providing care in cancer services, the extent to which people are engaged and engaged well from a CAL background is really variable dependent on the nature of the task, even within a cancer service. So if you're trying to have a scheduled appointment where you've been able to book an interpreter and it's about a very concrete issue that is easily translated into another concept and culture and language, then that might lead to a situation where, you know, the staff and the patients feel they've had a good engagement. You know, conversely, there are lots of informal conversations that are not had or that are not adequately had because either the terminology doesn't land well, the concept doesn't fit well for different cultures to communicate about it without that cultural support, or there is simply a lack of somebody available to interpret even something that could be interpreted. So even in just that small domain, there are lots of different ways in which the way that we provide healthcare is not meeting the needs of the communities. And then that plays out into kind of wider context as well, you know, and the wider context around what we need to do for accreditation as a healthcare provider and the policies that govern those systems. I was interested as well in what's happening in palliative care. We're doing a project around palliative care and advanced care planning with CAL communities across Australia. And we, as part of that, we've done lots of focus groups with consumers and staff involved in palliative care. And there's lots of different types of staff, obviously, involved in palliative care. We've interviewed translators who are having to be involved in those conversations. And some of the things that they mentioned were just interesting in terms of thinking about what's really causing a disconnect between the kinds of services that are potentially available to people and the way that they're experiencing those services. And several of the interpreters were talking about the issue of assuming that, you know, translation is going to be a verbatim conversation that's just converted into another language, and the inadequacy of that as a process to communicate about something that's emotionally charged, can be conceptually different really from one culture to another. What is the role of a translator? To what extent is their role to actually provide an interpretation into another culture? To what extent are they there to just translate the words, and some of the challenges that they face around that? And so again, that's, you know, this is an example in palliative care, but it really relates to other things that are happening in the healthcare system. I think something that's really interested us in terms of looking at health, you know, looking at models of care, and we go across in our work lots of different healthcare services and systems and think about how it's done. Generally, our approach has been to adjust features of a policy or a programme or a resource to try to meet CAL population needs. And so we think, oh, there's a general population, and then we're going to make adaptations for a CAL population. And often that's, you know, let's translate something directly, or let's add artwork, or let's make it more culturally appropriate in terms of adding a little bit of different wording or framing. And when we think about, there's lots of models around how you might do cultural adaptation. One of them is cultural sensitivity model, and that's one that I've thought about here, and that talks about the idea of surface adaptations and deep adaptations when you're thinking about cultural adaptations. And I would think of these as kind of surface culture adaptations. We're really heavily reliant on healthcare provision through surface level adaptations in terms of culture. Sometimes it can work quite well, but it really depends on what it is that we're trying to achieve. So we've done an analysis of, we were looking at really patient engagement techniques that are used in healthcare services. So there's lots of things, you'll probably see them if you go into hospital, you know, something where there's a poster that says wash your hands, and there's a poster that says have you asked health professionals if they've washed their hands, and, you know, how does that land for other people in different cultures. We were asking about those kinds of things with communities across Australia, and finding that, you know, for some of those kinds of interventions or programs, they can be adapted through a surface level adaptation quite effectively and meet the needs of different cultures to be able to engage with them. For others, there is a complete conceptual disconnect and misalignment between the nature of what is being proposed in that policy, process, programme, whatever it is, with the communities to whom which you're trying to affect some change. And it's not going to be well suited to a surface level adaptation. And that's when, we start thinking about what deep culture and deep culture adaptation might require. So, think about deep culture as being often something you're only aware of if you've been brought up within a particular culture or particularly born or raised in that culture. And it's things that are often more subtle and they're expressed in people's actions and words, but it's about their values and their thoughts. And how do we manage the issue of being able to provide care that addresses these kind of deep culture, where deep culture adaptation might be required? And I think we've gone to a place where everything is intended to be co-designed, and although well-intentioned, it may not necessarily be possible and actually that effective in all areas. So I think, there's lots of opportunities to co-design things with communities to try to better meet their needs. That can be a really useful tool, but only really in instances where there genuinely is an opportunity for the outcome to be completely transformed by the user that's going to be involved in that outcome, where there's resources to support the process of actually doing a process of co-design. I think we've got a risk in terms of the way that we're kind of trying to co-design kind of healthcare service delivery policies and those kinds of things when those conditions are not met. Having said that, we have had some successful co-designs of solutions that are very much placed within a particular service, with a particular community, where the outcome can be completely designed by that community. And I think that can work. It can work in those settings. So a couple of examples here are of a medication management tool. And this was to try to help people understand where they could go about various different problems arising with their medications. This was for the Mandarin-speaking community in a very particular service within Sydney, and it has been working well within that community and well received so far. We've also done some things around helping Arabic-speaking community in Western Sydney to be able to access services that are already available to them in that particular district. And so those kinds of things have been quite successful through co-design. I think I'm interested in, I suppose, healthcare provider and management training. It's really focused around the idea of cultural competence, and we spend a lot of time trying to teach people to be kind of culturally competent. And I think, with that is a sense of you're going to be able to learn about somebody's culture such that you're always going to be able to understand and meet the needs of that culture. I think the concept of cultural humility is possibly of value, because that's more about understanding how your own position and background is able or not able to interact with another, understanding that you're not going to completely learn about another person's culture, but that you're going to be able to be reflective about your own kind of cultural standpoints and perspectives and recognise that they influence the interaction as do other people's. And I think it's a good starting point to think about how we move health systems forward. And then, that kind of concept applies really to all aspects of kind of health service delivery and the way that we think about how we enact our kind of health systems and health service provision. So I'm going to wrap up there, but I think the main points that I want to highlight around health service provision and thinking about engagement really relate to the fact that we have still really poor diversity data, and even when we do have good diversity data, we don't use it very well in terms of reflecting kind of inter and intragroup diversity, what that actually means for then how they move through systems of care. There's a real kind of, on one hand, sense that we should be doing everything in partnership, and this idea that partnership is really important as a value, certainly in the healthcare system, but then resourcing partnership is really inadequate, and so that doesn't happen in an effective way, and we actually end up potentially causing more harm than good. I think person-centricity and cultural humility are really important concepts for kind of improving the way that we try to advance kind of healthcare provision for CAL communities. And I'll wrap up there, and thanks very much.
Thank you, Professor Harrison. That was really insightful, especially for researchers like me who are just getting into research on health services for called communities. Now we have Dr. Fiona Stanaway, who will share her insights on health outcomes in Australia's culturally and linguistically diverse populations. Dr. Fiona Stanaway is an associate professor at the University of Sydney and an associate investigator at CEPAR. She's a medical doctor and a clinical epidemiologist who is passionate about the better use of data to identify health inequalities in Australia's ethnically diverse population. Her current research involves a data linkage project that is linking the 2016 census to New South Wales hospital data to examine ethnic inequalities in cardiovascular disease. As part of this project, the team is looking at ways to use the ancestry data collected in the census to group Australia's population by ethnicity. Please join me in welcoming Fiona Stanaway.
Okay, so I'm talking about health outcomes in CALD, and one of the things that I'm passionate about and that I'm really going to focus the talk on is the diversity within the CALD population. So we often talk about CALD as if it's one group of people, whereas in fact it's a very diverse group of people, and there's often more differences between CALD groups than there are between CALD and non-CALD in the population. So I'm just going to be giving some examples of that in the talk. And so that can firstly depend on how we define CALD, what measures, what cultural language measures we use, whether it's country of birth, self-reported ancestry, language spoken at home. And one of the particular focuses of my work is trying to use the ancestry data, which I agree is terrible. And I was one of the people that advocated really strongly with the ABS to change the question, and unfortunately they are not. But it's all we've got, and we need to use it because it does identify people that are really not captured by the other measures. If you take the Lebanese population as one example, in the 2021 census, only 25% of people reporting Lebanese ancestry were born in Lebanon. If you think of Maori, you can't capture Maori by country of birth. And even the Pacifica population, 2/3 of that population are born in Australia or New Zealand. They're not born in the Pacific Islands. So it's important that we try and use this data imperfect as it is. It's also important to think about the assumptions we make when we aggregate very diverse groups together, often on the basis of geography rather than on the basis of what their social determinants, values and behaviours might be that drive very different health outcomes. And then it's also really important which health outcomes we're looking at. We can see very, very different results in the same group depending on whether we look at mortality or different causes of morbidity. So all of these are examples of better ways that we can be using the data that we have. And as an epidemiologist, that's my real passion. So these are the two sources of data that I'll be talking about today in the presentation. So the first one is a data linkage project that I have funded by the Medical Research Future Fund. It's a project that links several administrative health data sets from New South Wales into what used to be called MADIP but is now called PLIDA, which is a linked data asset run by the Australian Bureau of Statistics. And so it gives us access to also a lot of Commonwealth demographic and health data sets. And from my perspective, what's important there is the census. As if you may or may not recall from one of Raf's slides, the census is the only place that the ancestry data is collected in Australia at the current time. The other data that I'm going to present is from the Concord Health and Ageing in Men project, which was a cohort study that was conducted, that started in the early 2000s. It recruited men aged 70 years and older from several inner Western Sydney suburbs of Sydney. And because of the suburbs that were chosen, they recruited a large number of Italian-born men into that study, and that was actually the focus of my PhD that I completed a while ago now, but it's still relevant for today. And so firstly, talking about why data linkage, and some people have touched on this already before. This is a great report produced by the Federation of Ethnic Community Councils Australia, and looking at which different measures of cultural and language diversity are available in different administrative data sets. And the bottom line is it's country of birth, and sometimes not even of good quality. And so at the moment, data linkage is the main way that we can overcome this deficiency, by linking predominantly the census to these other health data sets. The other reason is this. So these are the main cohort studies in Australia, and they almost universally underrepresent older called Australians. Although CHAMP looks very good on this slide because it did have a lot of called participants, they're all men, and they're mostly men born in Italy. So it still doesn't really tell us a lot about called ageing, unfortunately. So this is a very busy slide, but don't worry, I'll go through it. So this is some of our linked data work. This is linking the 2016 census population to the death register and comparing country of birth and self-reported ancestry. The dotted line down the centre is the average population mortality rate, stratified by sex, Marion. And you can see that, in fact, for a lot of groups, there really isn't an important difference between country of birth and ancestry. So country of birth is in blue, ancestry is in red, but there are groups at the top where the difference is really, really important. And so I'll talk about them specifically on the next slide. And this is really what you would expect. So, of course, we don't capture Maori by the country of birth, New Zealand, and you can see that they're, particularly in women, that the average mortality is quite different. But it's also really important for Pacifica. So in fact, looking at country of birth, sometimes Pacifica look like they have a mortality advantage or no different mortality to the average population, whereas when we look at ancestry, in fact, the mortality rates are substantially higher. And there are a number of reasons for that. So one is that that people of different ethnic backgrounds can be born in the Pacific Islands. So people of European background, people of Asian background, and they often have better health. But the second reason is what a few of the speakers have talked about already today, which is the selection effects associated with migration. And you can actually see those by looking at the difference between different visa classes as well. So if you look at the red colour first, which is the overall results, so this is data that is linking the migration data again to the death registry. Unfortunately, migration data only goes back to the year 2000. So keep that in mind when interpreting the results. But you can see, as you might expect, that the mortality benefit's stronger in the skilled migrants, and particularly in men. And it's actually the lowest in New Zealand citizens who can come to Australia much easier than through the other migration pathways. And you'll also see that over time that the mortality benefit decreases. And if we have data going back to a longer period, we would expect this to approach the population average, because that's how these selection bias type of effects usually work. But of course, it's important to keep in mind that this is just mortality, it's not morbidity. And so if we think about humanitarian migrants, for example, there's well-established literature that they can have high morbidity for a number of different conditions. And that was what I was saying before when I mentioned that it's important to look at a number of health outcomes and not just morbidity. And in fact, in some migrant groups, we have what we call this morbidity-mortality paradox, where quite low mortality can coexist with quite high morbidity from a number of conditions. And this has been observed in a number of different countries and a number of different groups, including Hispanic migrants in the United States, a number of different migrant groups in the UK, Italian and Greek migrants in Australia, and Turkish migrants in Germany. The causes are still debated, but it's thought that probably one very important contributor is different rates of either or both cardiovascular disease and cancer, which are really important drivers of mortality, whereas you can have high morbidity from lots of other conditions that don't kill you quite as fast as those two. So arthritis, chronic pain, poor mental health, disability. And so that has a really important consequence for healthy ageing, that combination. And so I looked at this a little bit in the CHAMP study. So this is comparing mortality, all-cause mortality between the Italian-born and Australian-born men in CHAMP. And if you look at the second line there, when we adjusted for age, there wasn't really a very convincing mortality benefit. But when we adjusted for the large socioeconomic differences between the two groups, we found that the Italian-born men were living much longer than what we would expect, given their very low socioeconomic status. And then despite that, they had much higher morbidity. And so particularly in the younger old men in CHAMP, so the men in their 70s, you can see that there were higher rates of disability, mild cognitive impairment and dementia, depressive symptoms and diabetes in the Italian-born compared to the Australian-born men. And one of the important drivers of these differences in morbidity was socioeconomic status. And it was there across virtually all measures of SES, but I'll just show you one of them, which was education. And you can see these really huge differences that we don't normally see in the population, where more than half of the Italian-born men in CHAMP had only a primary school or lower level of education. And that was a really important driver of high morbidity. So why did they have low mortality? Well, we're not sure, but we think part of it might be their diet. So even after being in Australia for more than 60 years, if we looked at their diet and how much they were adhering to a Mediterranean diet, we see that the Italian and the Greek migrants still had these really high scores for adhering to that Mediterranean dietary pattern. And if you look at the figure on the right, we found that the higher score that you had for that dietary pattern, the lower was your rate of cardiovascular disease events, and an even stronger effect on all-cause mortality. So perhaps that's an explanation of why you see high morbidity driven by low SES, but you don't see as much the high mortality that you would expect from the same low socioeconomic status. Okay, but of course, sticking with the theme of diversity, there's a lot of diversity in terms of cardiovascular disease outcomes across Australia's diverse population, and that was the impetus really for my MRFF grant. And so this is some preliminary data from that project. This is the New South Wales, the 2016 census population of New South Wales. And here we've just grouped into small region based on ancestry. And once again, you can see the higher rates of cardiovascular disease events in Maori and Pacifica. Also higher rates in people of North African and Middle Eastern ancestry, and possibly slightly higher in some European groups and people that report multiple ancestries. But of course, even these small regional groupings, again, hide some important diversity. So for example, if we look at the European group, it's really just some Eastern and Southeastern European groups that have the higher rates of cardiovascular disease. The other European groups do not. And very importantly, in the Asian group, is that if you group all Asians together, you hide really important higher rates of cardiovascular disease in South Asians, because East Asians have incredibly low rates of cardiovascular disease, and that's well established internationally. again, thinking about the higher rates that we observed in the North African and Middle Eastern group, that is really driven only by people that have Arab ancestry, and no one else in that group shows higher rates of cardiovascular disease. And again, in the multi-ethnic group, it's people that are multi-ethnic European Maori that have the higher rates and not other groups. Okay. And finally, to finish, I can't go back. Finally, to finish, is really just to emphasise, just like we found in the Italian-born men in chat, the real importance of social determinants, of drivers of this diversity, both within different called groups as well as between called and non-called populations. So this is firstly just looking at education by self-reported ancestry. This first one is not age adjusted, so is influenced to a certain degree by the different age structures of these population groups. But you will notice, for example, Maori and Pacifica at the top are much less likely to have completed a university degree, whereas if you look at the Asian group, they have a very high rate of completing university education. And then in contrast, when we compare that to, we just limit it to the older 65 population, you'll see firstly the enormous difference in education level in that older population, and particularly in women. And particularly two ancestry groups that have a very low rate of completing high school are the other European, which are mainly Southern Europeans in that group, and North African and Middle Eastern. And so this provides really important information about when we see differences in health and healthy ageing in these population groups as to what some of the important drivers might be. So in summary, called populations are incredibly diverse in terms of health outcomes. It's important to look beyond country of birth, even though that's the most commonly collected and easily collected measure. And that's particularly important for identifying health inequalities in Maori and Pacifica, which are growing populations in Australia. There's also really important differences between individual groups, and so having granularity of data is really important, and as much granularity as your sample size permits. And maybe I'm being controversial, but I think if your sample size is only large enough for you to present data as called, non-called, maybe don't do it, because all you'll be producing is really misleading information. There's also really important differences by health outcome. So if you're wanting to understand health in a particular community, you need to look at multiple health outcomes because they might sometimes have these paradoxical effects. And finally, social determinants are really important drivers of health inequalities within called, between called and non-called, and key to understanding inequalities in healthy ageing. Thank you. Sorry, I forgot to thank my wonderful biostatistician who produced a lot of the figures, Lynn. Okay.
Thank you, Fiona. That was really enlightening, especially this distinction between high mortality and high morbidity. I didn't expect people to have that sort of high morbidity but low mortality. That was very interesting. Now we have our third speaker for the day, Professor Julie Byles. Professor Julie Byles is Global Innovation Chair in Responsive Transitions in Health and Aging at the University of Newcastle. As a clinical epidemiologist, Professor Byles' interests are in risk determination, health assessment, other healthcare evaluation, and measurement of health outcomes. As a gerontologist and fellow of the Australian Association of Gerontology, Professor Byles' research interests in aging include the role of health services, preventive activities, and treatments in maintaining quality of life for older people, and in determining physical, psychological, and social factors associated with optimal physical and mental health of men and women as they age. She is also the head of the International Longevity Centre Australia and co-president of the International Longevity Centre Global Alliance. Please join me in welcoming Professor Julie Byles.
Thank you very much for that. And I think most importantly, I'm here today as a CEPAR Associate Investigator. So thank you, John, and the team for inviting me. So I'm going to just get my slides up. There you go, put it on the slideshow. So I'm actually going to present a study today that we did was part of our CEPAR work, and it was with Hal Kendig and a team of people from the UK involved in the English longitudinal study on ageing. And so in this study, we compared English migrants to Australia with Australian-born Australians and English people who stayed in England. So we were really looking at these different effects of migration. Now, that probably doesn't fit into the culturally and linguistically diverse category unless you want to look at diversity within diversity. But what it did provide is a useful framework for looking at some of the theoretical migration effects. And so looking at that, I'm then going to reflect on what our previous speakers have spoken about. So what we did technically, and you can read the paper, which is in the Journal of Ethnic and Migration Studies, but what we did is we took a sample of people from the SACS 45 and up study. We surveyed and interviewed them using life history framework, so we could go right back to their origins and their parents' origins. And we oversampled people who'd been born in the UK, but to be in, they had to have come out after 18, and most of them had come out before, around the ages 30 to 40 years. And then our comparison group of people who stayed in England were the English longitudinal study on ageing. Now, all of the people in the sample were aged between 60 and 65 years, because we were looking at the sort of leading edge of the baby boomer cohort, and that's their age at that time. Now, the framework I'm going to apply is on three different aspects that may affect people's health as migrants. And actually, I have to share with you that we were written to by one of our colleagues, Anna Howe, who said maybe we shouldn't use the words migrant because it's probably it's very laden, I think. And that's probably true, and I think that's the diversity, because when we're talking about why people come to Australia from another country, there's all sorts of reasons, and migration is one thing, but being labelled a migrant might be a completely different thing. So I just use that term with tremendous caution. My family came out here as convicts, so somehow there's a greater pride in that term nowadays, maybe. So one of the things that might have affected the English migrants coming to Australia was selection bias, and Fiona just talked about that quite a lot. And if you're coming here as either skilled labour or unskilled labour, you're going to require good physical health to be able to work. If you're coming to fill a gap in skills, then you're going to have either higher education levels or training in specific skills and professions. And in fact, among our UK people coming to Australia as adults, they did have higher education levels and specific skills and professions. But interestingly, in terms of what affected their health, it wasn't having a university degree, it was more having those sort of middle levels of education. So it tells us something about those people who came. I think there's just a natural resilience and bravery among people who choose to come to another country, tremendous admiration for that, for everybody that we've been talking about today, and a resolve to succeed. So we should never underestimate that in those people who choose or come to Australia for other reasons. Then there's a concept of a salmon bias, and that's not my term either. But about a quarter of the people who came out actually returned to the UK within a couple of years of migrating. So it's interesting you've got a selection effect on your selection effect. But then within that group, there's what they termed the boomerang migrants, where 1/3 decided it wasn't so good in the UK after all, and they better come back to Australia because it was actually better. So there's a really interesting effect there of selection upon selection upon selection. Now, in terms of what people have said, Fiona talked a lot about the Italian men and how that the difference between country of birth and ancestry, and the selection bias there in that, if you had the skilled people from New Zealand, for instance, if they had lower mortality if they were skilled and educated, but not so much if they weren't skilled and educated. So it's not just an ancestry effect, it's a selection effect. But in some other work that some colleagues of mine did in the Hunter Valley, one of the things they found that the Welsh people had much higher rates of cardiovascular disease, and I'm not sure if you've come across this, but that seems to be an ancestry effect rather than an education effect, which I think is quite interesting, and it reflects the higher levels in Wales as well. So but the Italian men, interestingly, had lower education, so it wasn't so than the Australian-born men, so it wasn't so much an education effect, but I think a healthy labourer effect, perhaps, but also perhaps this propensity to take risk and this bravery and determination to succeed. I also point out about the diversity within populations. So if you look at, for instance, you very sensibly, Fiona, subdivided your Asian group into subgroups, but we did some work again with CEPAR and our colleagues and Hal Kendig and colleagues through CEPAR, where we looked at diversity within China, so Chinese people in China, and massive diversity there according to region, rural and urban differences, and of course socioeconomic status differences. And we mapped the relationships between the dietary differences that went with those groups and birth cohort dietary differences and ageing dietary differences, and looked at health differences, and all those things added up to quite substantial health differences. So I think that's just reminding us about diversity within diversity within diversity. So looking at adaptation, now this is the idea that when you get to a country, you do make some big changes. So one of the things is being able to have psychological adaptation and ending up in good mental health. And we think this happened for our English migrants because they had much better quality of life measured by the CASP scores than the Australian-born. So, you know, in that somewhere between that propensity to take risks and their time in Australia, they managed to maintain or develop and evolve very good quality of life. They also had less functional limitation at ages 60. They might have also, but we didn't see it, have better sociocultural adaptation, some better cultural knowledge and social contact and intergroup attitudes. And I think Reema talked about this being very important in terms of healthcare. And I think that what I wrote down when I was listening to Reema's presentation was about why can't we learn more from the people who come to this country? Why do they always have to be learning from us? I don't think that's necessarily the right way around. There's a thing about economic adaptation and having a satisfying job, which might help these people age better. And then the point that was made earlier today about the healthy migrant effect not necessarily lasting and eroding with increasing lengths of stay and over generations, so they become more and more like the new population. And we see that when people move to America, they get bigger. And we also saw it in a study of diets of Chinese women who'd moved to Chinese-born women who'd moved to Australia, and we compared their diets. They were better than the Australian women's diets of the same age, but not as good as what they would be if they were still in China. And then the third concept is advantage. So this is the idea that you get cumulative advantage across the life course. So if you start off ahead of the race, you'll probably end ahead of the race, but you'll pick up speed as you go along as well. So you know, if you start off with skill and you are hardworking and a positive attitude and all the rest of it, you'll end up getting promoted and get more occupational prestige and higher status in society. So you can actually see socioeconomic advancement through these cohorts that move to Australia and do well. But Reema talked a lot about the disadvantage and the exposure to risks, particularly for people working through the healthcare system. We also saw that paradox about having less diseases and more but worse quality of life. And some of that might be due to less detection of those diseases rather than them not actually having them, or later detection of those diseases, but it also might be due to worse healthcare, poorer access to healthcare, less quality, worse safety, and that might translate into poorer adherence and understanding of their healthcare condition. Another point I'd like to make out in relation to healthcare, and it's one generally, but I think it relates as well, especially to different cultural groups. We talk about healthcare being person-centred, but we need to talk about it being relational, because it's always about a relationship between people, and that's why your interpreters need to be part of that relationship and assisting that relationship between the person and their carers. And just on that other point about that, because Reema, your talk brought up so many things for me, is that the idea of co-design and cultural competence, again, it shouldn't work one way. We've talked this morning about numbers, and we know that the politicians have taken their numbers to the electoral platform, but we should be talking about people. And so when we're talking about community influence and cultural competence and co-design, we should actually be looking at the broader community and making sure they understand what it means to have people coming to Australia, that means we have nurses, that means we have doctors in our public health systems, that means we have people working in aged care. If we have a lot of students come, that's actually an export, because we're exporting education, it's adding to our balance of trade. So we need our leaders to engage in a much more nuanced conversation with our public and not pander to prejudice. So I think that's probably the point I really want to end on, perhaps thinking beyond the numbers and thinking about the people and really challenging what those people bring and what they mean to us as a country. Thank you.
Thank you, Professor Byles. That was actually very interesting, especially the framework that you've provided us to use when we're looking at migrant healthcare and their healthcare systems. Now we have our next speaker, Bianca Brijnath. Bianca Brijnath is the Divisional Director of Social Gerontology at the National Aging Research Institute, NARI. Her disciplinary training is in medical anthropology and public health, and her research expertise is in cultural diversity, dementia, and mental health. Within these disciplinary and contextual boundaries, she has undertaken several studies on dementia prevention, awareness, diagnosis, and care, specifically to culturally diverse communities in Australia and overseas. Please join me in welcoming Bianca Brijnath.
Thanks very much for the invitation and for the opportunity to speak. I've been invited to be a commentator for the session this morning and this afternoon. So in preparing for my talk, I read the brief, which I really enjoyed. Thank you very much, Rafa, for that. And I've tried very hard to listen attentively. So there's a couple of key things that I've taken away from the talks this morning. First, Australia is an increasingly aging and multicultural nation. Well, we all knew that. Second, that the called communities that are currently over 65, mainly European-born cohorts, will not be the older called cohorts we will need to service and care for in as little as a decade. Instead, there is a demographic transition underway in Australia, where an older called populations will move from predominantly European to Asian-born, and that the proportion of poor to low English proficiency amongst older migrants will decrease, but pockets of disadvantage, particularly amongst older Chinese and mainland Southeast Asian migrants, will remain. And that disparities in access to health and aged care, and therefore their attendant outcomes, will remain between called and Australian-born people. So in considering what contributions I could offer to these very rich findings, what immediately struck me is that I'm actually a bit of an embodiment of some of this data. So I'm a called woman, I'm from India, I'll definitely be over 65 by 2056, I'm proficient in English so far, and we'll see how we go by the end of the talk. But I'm really hopeful that in about 30 years' time, my income, my health, and my care will be commensurate with others in this room who were born in Australia. And so in a bid to ensure that I don't age with disadvantage, I'm going to put forward some policy and practical implications for some of the data that's been presented today. So let me start with language. And I want to make the very simple point that culture and language are interconnected, but they are not the same. And too often they are treated as if they are. Now, ethno-specific aged care is much more than just the provision of care in a relevant language. It is about offering the benefits and reassurance of culturally familiar care through food, recreational activities, spiritual and religious practices, and end-of-life care. Now, this type of care need not solely be the provenance of ethno-specific providers. Mainstream ones should also deliver it. Mainstream providers must be inclusive of all the Australian communities they serve. There are legislative and policy requirements that sort of make that statement, and the exposure draft of the 2023 Aged Care Bill makes that very clear. More importantly, apart from the niceness and the kind of policy imperatives, if providers wish to remain financially solvent and even increase their market share, catering to an increasingly diverse older clientele is crucial. You can't leave the delivery of culturally specific care solely in the hands of ethno-specific providers. That's a very risky strategy. Because when we look at what ethno-specific care is actually available in Australia, what we see is that it is predominantly for established CALD communities, mainly Italian, Greek, Chinese, and Vietnamese communities. But the demographic projections that Raphael and Jeremy presented make very clear that some of these organizations may not actually have the specific older CALD populations to serve in due course. These organizations might well become obsolete, and other ones will need to be developed and scaled up. So this is an issue of equity and access as well as business continuity. And we really, really urgently need research into how the needs of CALD communities which currently lack access to ethno-specific care can be effectively serviced by mainstream aged care providers. We need further research into how ethno-specific services that will be redundant because they may not have the clientele to service can transition to caring for other communities or be future-proofed in other ways. And we need to think about how sustainable, culturally appropriate models of care can be developed and delivered in the long term. Now, I don't want to kind of make this like a very depressing talk to end on before lunch, right? So one, I think, exciting thing that's already in play is actually the growing cultural diversity of the aged care workforce itself. Already about 40% of the direct care workforce is from a CALD background, principally from the Philippines, India, Iraq, and Sudan. Guess where our older CALD communities are coming from in the future? So for the first time, there might actually be opportunities to culturally match staff and older people, which we've not really had in the past. Now, we have done some work with aged care organizations where this was occurring. And we found that where this did occur, staff where you can culturally match the staff end up functioning as boundary crossers. So what they end up doing is they undertake very critical work in combating many of the barriers to health and aged care that Reema discussed, and she presented in that slide up at the beginning. I thought it was a very effective way to capture that data. And what these boundary crossers will do is they will often connect community with health and aged care systems. They'll build trust and rapport between clients and services. They'll assist with service navigation to improve access. They'll often overcome the stigma around formal help seeking that we see in many CALD families, which is often framed as resistance to having outsiders enter into people's homes or to entering into respite care or even, God forbid, going into residential aged care. So boundary crossers will do a lot of that work, and we found that they do this work strategically by using English and other vernaculars, clinical and cultural terminology, negotiating cultural, social, and professional boundaries. And often this work will involve education, advocacy, negotiation, navigation, creativity, and emotional engagement, and it is not remunerated. So I think we need to really start valuing the increasingly diverse aged care workforce that we do already have. That is an asset, right? Principally also because many of these staff intend to remain in aged care. It's often perceived, we did some research with the workforce, and the CALD workforce says, aged care is perceived as family friendly. It offers flexible working hours, and that the workers see enormous moral value in the work itself. And for a sector that needs to triple from 370,000 to almost 1 million by 2050, we really need all the help we can get. And so these staff can really help build capacity in health, aged care, and community care sectors, including in how to develop and adapt resources to deliver culturally and linguistically responsive services. Now, working with and for CALD communities to meet their needs, really the fundamental tenets of co-design, which Reema again described very well, is really crucial, because looking to the future, we have to identify ways to design services, reduce disease risk, extend healthy active years of life, and compress morbidity through lifestyle-modifying interventions. The drugs ain't gonna save us, right? By 2051, I did some work with Jeremy, and based on cohort flow alone, there's going to be an over 400% increase in dementia in people who were born in Southeast Asia, Southern and Central Asia, and Sub-Saharan Africa. And the Australian-born increase will be about 144%, right? But if you look at where dementia risk reduction messages are going, it's not really making it into multicultural communities. And when these messages do, they're often not culturally adapted. And this leaves many communities struggling to apply that information. So let me give you a little example, right? So the one time I encouraged a community group of about 20 older Indians to use olive oil in their cooking because there's good evidence for olive oil, I was met with rage, right? And people said, "You must be a shill for the olive oil company." I sadly have no shares in olive oil companies. But it did make the point to me that we really need to adapt the evidence to make it salient and relevant, right? And people often will have those solutions. So, once people got over being enraged with me, then there were questions like, can we use ghee instead of olive oil? And is Sudoku a form of lifelong learning? And what's the Indian equivalent of an olive? Because we don't want to eat olives and feta cheese all day long. And on and on it went. But what it really brings home is that co-design with CALD communities is vital here to promote a healthy lifestyle, to increase pleasurable activities and social connections, to reduce dementia and other chronic disease risks in culturally adapted, acceptable, and accessible ways. And of course, these efforts, co-design is not an end in of itself, and it's not going to overcome the structural burden that so many CALD Australians shoulder in seeking services for their older family members, right? So when you're talking about managing complex interactions within the kind of fragmented structures of formal health and social care, building health literacy and health systems literacy in CALD communities is not really going to fully sort it. This is an issue where we kind of tend to frame it as a CALD problem, but that's a very inadequate framing in my view. Government services and policies really need to be structurally and culturally competent. And this, I think, begins by starts by not describing CALD communities and the barriers that we face in accessing aged care as the problem of a thin market, which is rhetoric that's really commonly used by the government, right? And for those who aren't aware, a thin market is an inadequate market provision which results in CALD older people potentially missing out on services or being forced into services that don't meet their needs. So I just want to push back on that rhetoric a little bit, because first, we're not a thin market problem, we're a population. Two, thin markets don't exist like gravity and green grass. They just kind of don't exist. They're, the natural thing. They can be changed, they can be thickened, so to speak, and we really need to examine the market settings. So how are CALD communities being involved in their services? Are resources being pooled? Have bicultural staff talents been harnessed? Is there an organization-wide approach to address racism that permeates the entire aged care sector, and especially directed against CALD staff? And so these are just some mechanisms by which you can challenge those things, and I think, thicken up the market. And I think obviously a whole heap more needs to be done in health and aged care, but I think as the modelling that CEPA's done shows that, CALD Australians are very fundamental to national productivity, fertility, and most definitely the economic viability of aged care in Australia. So thank you for that.
Thank you, Bianca. This has really been a very rich and interesting discussion up until now. I'm going to ask the speakers to please join me on the floor for question and answers. We have about 15 minutes, I think, to ask the panel questions, and we have 2 mics in the audience. So please, if you have questions, just introduce yourself and ask questions clearly and concisely for the benefit of our audience online. And we can start soon. Okay, I think there's one. Oh, okay. I have one there.
Thank you, Fiona. That very interesting difference between mortality and morbidity for older, mainly Southern Europeans. One issue is that a lot of Southern Europeans worked in manufacturing industry, and maybe that had an impact, but it also meant that they lost their jobs when manufacturing industry declined, and they lost their jobs before they reached pension age. What did they have to do? They had to go onto the disability support pension. So they had to kind of prove a disability, as it were, in order to get their pension. And so there might be a little bit of inaccuracy around the stated disability, compared to the Australian population.
Yeah, I agree. The disability, though, it wasn't just for activities of daily living, though. It's also for instrumental activities of daily living, which is more a measure of cognitive impairment than just the physical activity. So it was in both. But yeah, we did find, I mean, this is going back quite a few years to when I did my PhD, which is a while ago now, but I did find that, so they had much worse chronic pain and particularly back pain, and that was very strongly related to occupation, yeah. But it's education as well, because with chronic pain, it's not just having an injury, it's the way you conceptualise that pain and you think about it. And so having a lower education level also increases your risk of that injury and the pain from that becoming chronic. So it's kind of both, yeah.
Thank you. Mine's not so much a specific question, but to thank you all for such very interesting presentations. And I think, Marion Baird from the University of Sydney, to thank you all for your presentations, because I think they really showed us that we need to frame migration not as a cost to Australia, but as a benefit. So that the first session, which was really illuminating on the numbers of the day and what's happened in the shifting demographics of our population, your session really demonstrated, I think, that we take in migrants for particular purposes, often in aged care at the moment. Previous years it was in manufacturing to build the Snowy Mountain scheme or whatever we were doing, car plants. And it made me also think that if we could change that discussion somewhat, we would also realise that we need to pay back in some way as a community what these people have brought to Australia, so that we sort of see it as an investment in the country, and now it's time to say, well, here is the return on what you brought to Australia. Now, I know that's a hard sell in a political situation where there are deficits or a need to provide a surplus, but I do think that being able to provide I hate to use the word nuances, but the intricacies and the differences amongst the population that came to Australia and now their needs, we really do need to start sort of sharpening and contributing that to our policy discussions. And I just want to mention, because I did pick up Bianca, your lovely comment that we need to remunerate the aged care workforce. I sit on the Fair Work Commission, and we did provide in our recent aged care decision great recognition of the invisible skills that those workers have provided, and did see a huge increase in their pay. But it's still, if you look at weekly pay rates for aged care workers, it's still not huge. So it's also another thing we have to consider for the future, because they will become a very large segment of our aged care, of our population, if they stay in Australia and are returned to their home countries, which of course is creating another issue around the region. But thank you all. I don't know if you want to comment on that, but really just how we shift that debate a bit and recognise the benefits of migration.
I'll comment specifically on aged care because I've been working in the area of aged care workforce for the last couple of years. And I think one of the big problems we have is with the Australian population who are recipients of aged care and the people who support them not wanting a worker from a different cultural or language background. And of course, the waves of people who are providing this work is changing and changing and changing. And increasingly people will be coming from Africa. And so, you know, that's another level of challenge for people. So I think we do need to, I've always argued that we don't equip people to age, we don't equip people to be negotiators and recipients of aged care, and we most certainly don't equip them with how to have relationships with the people who care for them, even if they're not from a different background. But then we need to take it one step further and get them to embrace what you can get from a different background. And then just to flip that on its head a little bit, I had a bit of revelation myself a few years ago where I had a student come from Pakistan working with me, and I ran all my students as a group, so they all talked about each other's projects, and we had somebody working in aged care about the impacts of death and dying on the aged care staff. And what Shazia said was, like, and I hadn't thought about it, but the people who come from overseas to work in an aged care facility in Australia, this is an absolute anathema to them, the concept of putting your older person in an institution. And so then I thought, wow, they probably think we don't value our old people. And so, you know, that just the mind flip that they must have to go to even do that work. So, yeah, that was probably a bit off the point, but...
First, thanks, Marion, for the pay rise. I think it's a very significant and important recognition of the enormous contribution that these staff make to care. Your question was, how do we...
Funded, of course, and I think that just have to point out it was government funded, which makes the decision much easier to get to. I mean, it's a very important thing to think about because you still have to have the criteria on the, you know, how you make those wage adjustments. But knowing there is funding to back it up means it's not a disputed outcome.
Yeah. And going to your other question of how do we, reiterate at a political level the contribution and importance of migrants. I think the first thing is, you know, and Peter's done this, I've heard him on the radio several times about this, we actually have to separate the conversation between migration and infrastructure, because they get yoked together in public discourse all the time. You know, the traffic on the roads and I can't get housing and all the rest of it, and it's all, you know, because of migration, when in fact it's because of chronic and systematic underinvestment and, you know, not thinking about planning for the future. So I think, you know, that's the first thing, separate the two issues out. And I think the other business of migration is we somehow, multiculturalism is actually incredibly successful in Australia, and unlike the UK where they kind of keep, every so often they keep proclaiming it's dead and then suddenly it just rises again. We really need to recognize that diversity is a huge strength of this country. Like and in all sorts of ways. So I do a lot of medical research, right? So if I think even about diversity that we've got in our population, relatively safe, relatively stable country, there's all these people here who could take part in research, you know, who would just get excluded from it, for example. That's a huge, you know, way to build economy, build strategy, build capacity, et cetera, et cetera. So I think we've really got to kind of recognize those talents and what we could do with it and stop framing it as a problem and as the kind of, you know, the cause of infrastructure deficits and, you know, deterioration.
Thank you. Margaret Martin from Home Affairs Language Services Policy. Just would be keen on your views about whether government needs to go further than it has currently. We have a multicultural access and equity policy and language services guidelines, which are, you know, documents that encourage access and equity across all government service delivery. Do you think that it needs to go beyond a policy level, perhaps to a regulation or laws, to ensure that in-language support is available in either the designing and the service delivery in health and aged care and other sectors? Thank you.
Yes. So TIS National, which is the language support services that Home Affairs sponsors and is available across the country, is so chronically undersubscribed in many areas. And we have, if you're talking about health and aged care in particular, there is a huge suite of work that has to be done to shift the mindset of clinicians to actually employ interpreters, ring them up, you know, and use them instead of relying on the family members. Because that's the typical thing, you know, it's like, oh, well, it's too complicated, I can't be bothered making this phone call, it's going to take twice as long, forget it. You know, your daughter's here, she can do it, or whatever it might be. And then, you know, it really is, that is like the hallmark for poor quality care and for everything going downhill. So, yes, that's my view.
I think in the interest of time... Oh, okay.
That's fine.
No, it's fine. Go ahead. Yeah. All right, so in the interest of time, we're just going to wrap up the questions here. I'm sure you have a lot more questions, but maybe you can talk to the panel informally at lunch. So we're going to head out to lunch now. Thank you so much, everyone, and thank you to our speakers.